Hello, everyone. I'm Joanna Nixon.
I am Dr. Vilma Pacheco Barcia, and this is Open Doors Podcast, two women scientists driven by curiosity, evidence, and compassion.
Hi, everyone, and welcome back to Open Doors, the podcast we explore professional well-being in oncology and beyond, one conversation at a time. On this podcast, we open doors to better leadership, healthier teams, and practical tools for professional life. Today's guest is Dr. Nicky Thorp, consultant clinical oncologist, and her work focuses on radiotherapy for children and young people. And she brings decades of experience both in practice and in leadership. Today, we want to talk about what it means to care in a field that is so sensitive and asks a lot. It's very demanding. And how you keep showing up with steadiness, clarity, and care. Nicky, welcome.
And thank you so much for that introduction. And thank you so much for inviting me to join you on this podcast. I'm very excited about this and honoured to be asked.
Thank you very much for coming. Dr. Nicky Thorp is a consultant clinical oncologist at the Christie NHS Foundation Trust, specializing in paediatric radiotherapy and proton beam therapy. She trained in medicine at the University of Leicester, graduating in 1990, and completed her specialist oncology training at the Clatterbridge Cancer Center, where she worked as a consultant for 20 years. She brings extensive experience in leadership roles, including most recently as medical director for professional practice at the Royal College of Radiologists from 2021 to 2024. She was associate medical director at Clatterbridge between 2010 and 2016. She is currently co-lead for Wellbeing at the Royal College of Radiologists and has previously served 2 terms on the CO faculty board. Dr. Nicky Thorp has been elected as the incoming Vice President, Clinical Oncology. Dr. Thorp will officially start from 1st September 2025. Welcome to the podcast.
Thank you very much. Thank you. And you've done some very good research on me.
Nicky, your journey through oncology has taken you into some of the most challenges and delicate areas of medicine, as Joanna was previously saying. Treating cancer is always demanding, but working with children brings its own unique complexities and rewards. We can't really imagine how it is working. So, when you began this area of work, what did you discover about the kind of presence it requires?
I think when I first started, I really didn't know. Something that happened fairly early on is I had my own children, and that taught me so much about even treating children. The challenge of paediatrics is that you are treating a patient, but you're also caring for the family. The child does not present in isolation. And although that's the case for most of our patients, they have a family, the relationship between a parent and child is unique and special. And I think it's really important to be aware that you are caring for the most precious thing in that person's life. And the first thing you have to do as a doctor, as anybody caring for a child, is ensure that those parents can trust you. And unfortunately, a lot of parents will have had a very long diagnostic pathway, and it's often very distressing listening to the stories of parents, because fortunately cancer in children is rare, particularly the sort of tumours that I treat, brain tumours and other solid tumours. And if you're a GP, if you're a doctor in A&E, you don't see those cancers very often. So you don't immediately think of that as on your differential diagnosis list. And so often parents come having had a very long diagnostic route. They may have felt that they've been dismissed and not listened to, and you have to then rebuild that trust, because if they don't have that trust in the whole medical system, they can't they can't engage with the treatment, and they have to, because the treatments are complex, they are very toxic, they take a long time. What I do is only a small part of the journey that that child and that family will go through. But I think the first thing is trust and appreciating why parents may not trust you, and being humble and empathic, and really trying to put yourself in their shoes.
Thanks, Nikki. I think you've highlighted a number of issues, including how important is rapid diagnosis for children, identifying early signs of disease, and how distressing that can be for the families if they have been through a number of primary care, A&E frequently, in and out. You also mentioned the role of the radiation oncologist in that journey, in that very complex ecosystem, and the fact that it's so important to build rapport. How does this look like and feel like? How do you do it?
Okay, so I think this goes for any first consultation. I think for any patient, that first consultation is so important. That's where you make or break that relationship. And so I invest time in that first consultation. And one of the advantages of working in a specialist centre, and now having previously worked as an adult oncologist alongside my paediatric radiotherapy, I now just treat children. And I have the luxury of being able to spend time with those families. So I think, you can't rush that first consultation. You have to go at the parents' pace, and you cannot also say, right, I'm going to give you a little bit of information here. Haven't got time to give you it all, so you're going to come back and I'll then talk to you about the side effects. Although you feel it's overwhelming for parents to go through the whole lot of information about radiotherapy, the rationale for radiotherapy, the logistics, plus all the side effects, early and late side effects, what I found is that you have to do the whole thing. I always say, don't worry if you don't take all this on board, but they need to have some idea before they embark on that on their radiotherapy journey. And the only way you can do that and answer all their questions, because they come to you knowing very little. The paediatric oncologists are very sensible, and they don't pretend to know about radiotherapy. So they will say, apart from the bare basics, they will say, the clinical oncologist will talk to you about radiotherapy. So they come often not knowing very much. They've often been through surgery, chemotherapy. They've already taken a lot on board. And so you just have to give them time. You have to be prepared to answer their questions, or to say, I don't know the answer to that question. Nobody knows the answer to that question. You're honest and open as much as possible. And it's it becomes difficult talking about late effects, and that is, particularly in a young child, for example, who's having craniospinal irradiation, but been doing it for many years. And I think as doctors, we all adjust what we say, how we say it, to that person sitting in front of you. And that's almost an instinct that you develop. And it's the same with families and children as it is with adults. But it's that taking time, if that first consultation goes badly, I don't think you can ever win that back. You've lost that battle. So I do say to residents, take time over that first consultation.
Yes, Nikki, it's amazing how you've explained it, because that's what happens to us in our consults. We need to take care for the patient from minute one. We need to take our time, and we also need to be empathetic and understand their needs. And something that I really find very important is the relationship between doctor and patient. They they need to feel safe. So I think you're not just their doctor in that moment. You're someone that also helps them understand their own language, their own way of coping. But I truly am grateful for all that you've explained to us, because it's putting into words something that is very difficult to achieve in a day-to-day basis.
Yeah, and I think the thing about children is that they have they don't have really high expectations. They don't ask difficult questions. If you're nice to them, if you've got a nice box with toys in, they don't have to. I mean, the box I've got in my room is not particularly exciting, but if they, and I always try and talk to the child, not in a patronizing way, but just talk to them, ask them how they are, ask them how much they know, and that's really important, partly to relax them, partly for parents to see that I care about the child as well and I've got some idea about children, but also because it's really important to see how engaged that child is, to see how mature they might be. We're judging whether or not they make how they're going to cope with lying still, having the mask made, will they need an anesthetic, and actually having that conversation with that child is really important. And they're brilliant children. They'll just have this conversation, tell me all their mother's secrets. They're very open, and it is a joy. They're great, and they, as I say, they don't ask difficult questions. The most difficult question I think a child has ever asked me was, Dr. Nicky, can you speak at 1,000 miles an hour? Because I can. You don't get adults asking you stuff like that. So it is different. And I have to say, I haven't done a paediatric job. I didn't, during my training, I did not anticipate that I was going to be treating children during my career. The thought did not cross my mind. So in a way, you have to teach yourself, and obviously you read and you go to conferences and you learn about child development, but a lot of it is almost self-taught.
Thanks, Nikki. I should confess that I'm delighted to have you here because you're the first radiation oncologist that we have since we launched Open Doors podcast. So frequently I talk about how we need to raise awareness of how complex our job is as a radiation oncologist. I know that very well. Not just treating children, but for adults as well. So, how would you describe what we do in radiation oncology and what that involves on a day to day level?
I agree. I think most of our colleagues in the MDT have very little idea about what we do. Most people don't see any radiotherapy as medical students. They have no idea what a linear accelerator looks like. They talk about zapping and they say we burn patients and fry patients.
Fry.
And it's really, I think that is dying out, but there is still this idea, and they really have absolutely no idea. So when I'm talking to parents, I say to residents, the best thing, or even medical students, the best thing to do is to sit in on a new patient consultation, because actually it's good to hear it in straightforward language. But what do? We use radiation to treat tumours, mainly cancerous tumours, and we do that in a very controlled way. We define where the part of the body that we want to treat. In order to treat that part of the body accurately, the patient has to keep completely still. Hence, we use masks. I use general anaesthetics for children. We spend a lot of time once you've obtained the planning scans in the treatment position. We transfer those scan pictures to a computer, and we spend a lot of time sitting in front of a computer program outlining where the tumour was, identifying the margin, and then identifying the adjacent normal tissues, and all this is done. A lot of it is done by hand, particularly the tumour contours. We do it slice by hand. Now, yes, the computer is getting much better. We have AI, and our normal tissues, many of our normal tissues, it is done using AI now, but we still have to check them. And sometimes AI is great, and sometimes you think, why have you done that? We're learning, but it's very, very time consuming, and to get it right. And I say to residents, I say to parents, essentially it's a work of art. And then those plans go to our dosimetry physics team, and they'll spend a lot of time working to produce this beautiful dose map, which gives the required dose to the tumour, and minimises as far as possible the dose to the adjacent organs, the adjacent normal tissues. And each normal tissue has a different tolerance for radiotherapy. So we have to be aware of the differential doses that you can give to the tumour and the normal tissue. You judge whether or not you're giving too much dose to the normal tissue. What is the risk of that? What is the risk of giving too much? What is the risk of giving too little to the tumour? And you have to think about all these different things. And that is just the radiotherapy planning, which is it should be a huge part of our job. Actually, for many of us, it takes up it's given a few hours a week in our job plans, because we still have to see patients in clinic, counsel them, discuss all the things that I've talked about radiotherapy. We follow patients up. Many of my colleagues, I don't anymore, but I used to, many of my colleagues are also responsible for delivery of systemic anti-cancer medication, chemotherapy, but immunotherapy, lots of different sorts of drugs that we use. We also enjoy our leadership roles, and we can't resist. We can't resist saying yes to various other interesting things. People are passionate about research. We enter patients into trials. People are passionate about teaching, and people are passionate about making a difference, so quality improvement and other leadership roles, for example, in the RCR. So the life of an oncologist, it's not just about radiotherapy planning, although it's quite a huge part, but because our job plans are so full, and actually you often need time, quiet time, to focus on that. Unfortunately, it is still the case that a lot of possibly the most important part of our job, that this is our USP. It's done out of hours, because it's done after dinner in the evening, when you've got some quiet time and you're not being interrupted by emails. And I do feel that we need to change that somehow. So that's what we do.
Absolutely. I was thinking when you were explaining all of your work, because I'm a medical oncologist, I did a rotation 2 months in clinical oncology in radiotherapy. I was in the head and cancer unit and in the prostate cancer unit when I was resident. And something that really impacted me was how individual each treatment was. I think that's so important. I tell that to all patients every time we do chemoradiotherapy or they do radiotherapy. I explain to them that their treatment is going to be specifically for them. You know, that you make decisions that are incredibly precise and impactful. You were also talking about all the responsibilities behind those decisions, behind all of your work and the background of each patient. What does it feel like to hold that kind of responsibility, Nikki?
I think we probably don't think about it. We are doctors, and we're senior doctors, we're consultants, and I think that's the essence of our job. we make difficult decisions, and they're often very subjective decisions. That, you know, it's an art as well as a science, and sometimes, you know, there are aspects of medicine that are very much a science, coming up with a radiotherapy plan, but actually the judgment, there's a subjective judgment that goes on when you're shown a plan and you think, actually, I want to increase the coverage to the tumor there, but if I do that, that's going to increase the dose to the kidney. That's a balance. Look at the patient. You know, if it's a child, you have to think about the late effects. You take all those things into consideration, but really our training from medical school, our experience, means that we do that. We don't think, another difficult decision, how can I make it? You have to do that. That's our job. And I think if we did think all the time about the enormity and the implications of those decisions, we would be paralyzed. You have to appreciate that those decisions are important, but you have to make those decisions, and often you have a choice of, it's this or the other, and you can read lots of papers, you can try and be as objective as possible, but sometimes it just comes down to, what do I think, what is my opinion, is the best way to go. And sometimes you can discuss that with your patient and you can make that decision in conjunction with your patient. Sometimes when I do that, I feel that I am handing over a very difficult decision to a patient, and I sometimes wonder if that's fair, especially parents. Some parents want it. Some parents say, you are quite right, you are the doctor, you make this decision, this is too hard for me, this is my child. So I think decision making is fascinating, but it's what we are here to do. And I think the system expects that of us, and certainly our patients have the right to expect that of us as well.
Absolutely, and I should also add that radiation oncology is definitely a team sport, isn't it,
Oh,
Nikki?
yes.
And in this complexity, we've got all these amazing people who work behind the scenes, and the patient may never meet, basically, but they are doing their magic with dosimetry. They're looking at best ways of minimizing toxicity for these patients, best plans, and the radiographers that deliver the plan, and they see the patient all the way through on a day-to-day basis. So it's definitely a team sport, and we are supported in all of that by our colleagues, the radiographers, the people from physics.
Absolutely, I couldn't agree more. That's one of the best things about radiation oncology, is the fact that you're working with highly experienced therapy radiographers, physicists who know about things that would teach me things. It's such a team sport, and it's so enjoyable to have conversations, for example, about a plan with a physicist. They bring their experience and their knowledge, I bring mine and my knowledge, and we come to a conclusion, and it's so satisfying. So I completely agree. But it's the surgeons we work with, the medical oncologists, the specialist nurses. It is really a team sport, and that is one of the joys of what we do, that we're working with all these fantastic people. And I do think those relationships that you cultivate, and you do cultivate, or you should cultivate them at work, are so important, because good, harmonious relationships lead to better patient care. And it also means that you enjoy your job.
Absolutely. Yeah, definitely.